So just go back to that Platinum 10. That Platinum 10 rule applies to trauma patients. That means when the boots hit the ground from when you get there, from when the boots hit the ground to when you are taking off with that patient, it shouldn't be more than 10 minutes for your critical patients that need to go to the hospital ASAP. Okay. See, most critical decisions, so patient priority or severity, we get that right off the bat, right as you're walking up to the patient. You should be able to identify if this patient is going to be a priority patient or not priority based off their presentation. So whether to limit scene time or not, okay, which hospital or transport method is best for your patient. As far as hospital, it depends on what we're talking about. If the patient that's affected has mostly burns throughout their body, but is affecting one or multiple systems, then this patient needs to go to a hospital that specializes in burn patients, right? Maybe somebody with a hyperbaric chamber if they were in a smoking building. Now, as opposed to that, if it's a straight up just trauma situation where a car got entangled and there's just trauma, they might want to go to a level 1 trauma center, meaning they have everything you need for almost any trauma patient. So that's what it means as far as which hospital, because some hospitals specialize in certain things, and that's when that really matters. As far as transport, you go off of your patient's priority and how far you think is going to take you to get from the location of where your patient is to the hospital. If it's more than 20 minutes and your patient is very, very critical, you're probably better off getting a helo. Of course, it's all situational, but that's just your textbook stuff right there, okay? All right, so some things that will help you determine if your patient is severe or not. So altered mental status of less than a 14 from that GCS that we talked about last time with the head injury, all right? So if they have a head injury, the GCS of 14 or less, you can take that criteria off and mark them off as severe if you want to. Hypotension, systolic is less than 90 millimeters of mercury, that top number on your blood pressure, which could be signs of shock or internal bleeding. So internal bleeding is also known as internal hemorrhage, okay? Abnormally slow respiratory rate, it could be an indication of head injury or later stages of shock. Now, if your patient has low respirations because of a head injury, we're gonna go ahead and think that this patient might be in neurogenic shock because of a head injury, because it's related to that. And with neurogenic shock, what happens with your patient, everything just declines. There is no compensation. So blood pressure starts going down, respirations and heart rate start to go down gradually, and there is no compensation because the nervous system is what helps you compensate when your patient needs to compensate is what I'm using, but I'm trying to use something else. Whenever your body sort of balance itself out from bleeding or whatever is causing the shock, all right? So it compensates through the nervous system, and your head being the brain, obviously, would affect that. All right, let's see, determining severity, anatomic criteria. So any of these would put your patient at a severe level. So penetrating injuries to the head, neck, torso. And the reason for that is because the head and torso, the head and torso have your 3 vital organs, being your brain, your heart, and your lungs. So that's a pretty big deal. Your neck, there's a lot going on in your neck. You have your spine, your carotid arteries, you have your great veins in there too. So that's why these are also important. As far as extremities proximal to the elbow or knee, the only if it's penetrating object, it is a big deal. I mean, it's always a big deal. But the only reason why I could think it that would put your patient at a severe level is because if it's proximal to the elbow or knee, That proximal means that it's closer to your trunk, so to the core of your body, than the elbow or knee. So whatever's impaled in your body or your patient's body, that object is above your elbow or knee. So because of that, the vessels are bigger and could cause more bleeding, if the object was to move around or come out. And that's more of a what can happen afterwards. That's why I can see it being severe. All right, so chest wall instability. So again, we've seen that flail chest, and we talked about the flail chest, the paradoxical motion, and how that could cause more damage within the thoracic cavity. So we talked about that. We see 2 or more proximal long bone fractures. Again, proximal meaning that it's closer to the core of your body, to the middle of your body. That's the way I look at it. And one more time, the reason that this could be severe is because as you get closer to the core, the vessels are larger, they're bigger. Therefore, if they get lacerated or damaged, your patient can bleed out a lot faster as opposed to if it was distal, meaning further away from the core, going down towards your fingers or your toes. That is distal. See, more criteria. So crushed, we talked about that, a crush injury. The gloved hand just means that the skin was taken out of your hands. You see that a lot in manufacturing companies. When I was in the Navy, that happened to one guy because the lines get stuck they'll get stuck on a watch or a ring finger on some machinery, or it's like a part of the machinery, and it'll just take off whatever's attached to that. And it's always the skin usually, and maybe some flesh. Along with that, mangled, that's also if you see it, I can see that being common inside. I've never seen anybody mangled, but if it were to happen, I would imagine it would happen inside like a warehouse or some kind of manufacturing company. See, or pulseless extremity. And just more criteria, amputations, obviously, pelvic fractures. Pelvic fractures is kind of the same deal as with the neck. There's so much going on in the pelvic region. You have a high risk of infection, bleeding out. There's a long list of things that can go wrong with the pelvic fracture. Open or depressed skull fractures, and that's again that sensitive brain of yours. We want to take care of that fast and prevent further injury and paralysis. See, so special patients and considerations. Any questions so far, guys, at all? No? All right. See, older adults do not efficiently compensate for shock. Children may benefit by transport to a pediatric specialty. So with children, the thing about children is that they compensate really well. And I know I've talked about this, but it's definitely worth talking about, especially in the trauma setting. Patients, they can compensate very, very well for whatever's going on in their body. However, when they start crashing, they crash hard, and that's because their bodies are so efficient at keeping them balanced, to whatever it is that's going on in their bodies, whether they're bleeding out or some kind of other issue, that they will compensate up until the point where they just can't go no more, and they crash pretty hard. So you want to keep an eye out for these patients. At the same time, there are hospitals that specialize in pediatrics, like I think what's one of them, like Rady Children's Hospital, I think it's called. But so yes, those hospitals. Patients with certain conditions taking anticoagulants or pregnant. These two, we're talking about trauma, remember? So if it's trauma, if your patient is taking anticoagulants, they can bleed out because they're anti-sticky. They affect the platelets, so they can bleed out. Pregnant, what can happen with these is that the baby inside the mother can have issues, and your patient can bleed out like that. So in some situations, what you'll have is that you'll have a placenta that is torn, and depending on how badly it's torn, depends on how badly the lady will bleed out. Not only that, but it'll also have really negative consequences for the baby themselves too. And again, it's all situational. It depends on how bad the tear is, how long the patient's been there waiting, It's a lot of factors play into what can actually happen to a patient, obviously. So managing a multi-system trauma patient. So you practice with the crew, determine roles. So this is something that you'll come across this hopefully here in Fresno too, but I know in San Diego it was common practice that as we're going to a call, we already have an idea of what the call is about, right? So as we're going there, we're already assigning roles. Who's gonna do what? Who's gonna take vital signs? Who's gonna talk to witnesses? Who's gonna take the medical history? So as we get there, so when we get there, we all have roles and we go straight to our roles, and we don't look unorganized. We know exactly what we're doing and we look professional, and it's better patient care too. So it's better for everybody all the way around to just have roles and responsibilities before you even get there. So en route to call, review roles each member of the crew will have. Ensure scene safety. Obviously, that goes without saying. Don't ever get that tunnel vision. Always take a global picture of everything. Take it all in before you walk into the situation. Assailant may still be on the scene. Okay. See, analysis of the call. In a scenario with critical injuries, follow priorities determined by assessment. Obviously, right? So we're gonna go ahead and identify and take care of life threats first, especially for critical patients that are crashing or can possibly crash. Let's see, show good judgment, postpone taking vital signs. So as part of your medical assessment, one thing you should know is that medical assessment is not something that you're going to be doing for every single medical patient. You are not going to be going through that list for every single patient. And your vital signs is part of your secondary assessment. But sometimes you're so busy with the primary assessment with ABCs and trying to maintain your patient alive that you will never get vital signs because you're too busy trying to keep the patient alive. So that bullet point right there is real. It's really good. It's more realistic of what happens out there. Give the hospital staff time to prepare. So that just means call them ahead of time. Give them at least 10 minutes, especially if it's a critical patient. Have somebody call them in just to prepare for you. Let them know what's going on with the patient, what the main issue is, and just as much information as you can that will help this patient out. General principles of multi-system trauma management. Follow priorities determined by primary assessment. We talked about that. Attend to immediate threats. Okay, we talked about that. Reassess what to treat on scene and what needs definitive care. See, depending on your primary assessment, you may postpone taking vital signs. We talked about that. As you reassess your patient in the vehicle, call the hospital as necessary to update vital signs. All right, we talked about scene safety, ensure an open airway. We talk about this all the time. So guess what's really important for the NREMT? Making sure the airway is patent, it's open. All right. Perform urgent or emergency moves. Let me find a video for you guys on this. Just give me a second. Let's see, pause my sharing. Let's see, urgent versus emergency moves. I'm gonna look up. Let's see, moves. Oh, it's funny. Might came up first. Oh, maybe there's not one out there. Let's see, EMT. A guide to seizure management. No, patient lifting and moving, mass casualty exercise. emergency medical care, EMT training workforce, urgent versus no. Yeah, this one looks like it might be the best one to show. Mass casualty exercise. All right, I'm gonna share it, and then we'll go from there. So share that one. All right, can you guys see the video? I'm assuming you guys can see it.
No, I don't see it.
No.
All staff teachers locked down at this moment.
Yes, sir. FBI advised they're here on radio. There's a possible device in 214.
Obviously, you're going to have exit wounds. Close your eyes.
You okay? Yeah.
You can put it in your mouth between your cheek and gum.
You want blood?
You're obviously dead. Oh, come here. Get right here. I'm going to do a little bluing on your face. We're making her look more obviously dead. It's very important. That kind of gives a sense of reality that they're really doing with real casualties. And, you know, naturally, you're going to want to help the
Lockdown, all staff teachers locked down at this moment.
HIC reported shots fired. Yes, sir. FBI advising they're here on the radio. There's a possible device in room 214.
We saw HISD police's response. We saw them, approach the school, assess the situation, realize that it was something beyond their scope, and activate Houston Police and SWAT team, other tactical units that played, including FBI, bomb techs, etc. You name it, they were there. They're going to be placing combat tourniquets, using combat gauze, using a variety of different things to really try to stabilize kids that are critically ill before they come to us, which is good to know because you want to know what they're going to be coming with and how they're going to be presenting to you.
When you're coming out, what stats are going to be taken?
We've got 6 red patients.
And I think the biggest takeaway from working with some of these partners is that they're going to probably come to us in pretty good shape. Obviously, in the emergency center, we live in a world of controlled chaos most of the time. So some of us are very used to that. But this is kind of next level.
Some blood on her left. It's taken care of. Okay. We wanted to take care of the sickest ones first that needed the most immediate intervention.
Pour IVs in and let's get some blood.
It is controlled chaos, but you have to figure out how to take charge of the situation. It was scary. There are a lot of patients with different diagnoses, different things going on, and one of the things we had to figure out is how do we get everything done in the room and still have the ability to move the patients out of the room and get new patients in the room.
The radio, I was communicating with the triage team lead because he was getting patients coming in and would essentially determine where they were going to Team Red or Team Yellow, and communicating with him when I thought we had too many patients or we had ready beds for him to come to us.
In the actual EC. What we realized that today, right now, even with all our imperfections, this is where you want to be. These clinicians, these physicians, these administrators, they're going to deliver. The mission was lived out. It was impressive to watch.
Another patient, 16-year-old, large GSW penetrating through and through, abdomen to the back. Vital signs are stable. OR has been called, blood thinning's called. They're going to be going to the, going to need another OR in just a bit. Okay, OR 5. Thank you so much.
That was a cool little video, but it didn't help me out at all. So the difference between urgent and emergency is that with urgent, you still may have the chance to take spinal precautions. With emergency, you do not have time for that because it's something is making you take that patient out of that environment because it's a highly dangerous environment. So you're just taking them out as soon as possible, and you might not even have time to take spinal precautions. With urgent, you do. That's the biggest difference. All right. Scene safety, talked about urgent, emergency, adapt to the situation. That's the whole job in itself. All right, let's play this video, see what we have.
In a patient suffering from a gunshot wound, apparent entrance and exit wounds may seem to provide indications as to a bullet's path. However, a bullet may strike bony structures within the body, which will alter its path. In addition, what appears to be a matched entrance and exit wound may in fact be two entrance wounds, and bullets can end up anywhere within the body far from where they entered.
Okay.
In a patient's
just a few more videos, guys.
In the down and under pathway resulting from a front-end collision, the unrestrained occupant slides downward as the vehicle comes to a stop. In the down and under pathway resulting from a front-end collision, the unrestrained occupant slides downward as the vehicle comes to a stop. The knees strike the firewall, leading to knee, femur, and pelvic injury. In addition, collapse of the firewall around the patient's legs can result in further injury and entrapment. The upper body then rotates forward, and the chest strikes the steering wheel, resulting in chest injuries. The use of a seatbelt and airbag can help to lessen the risk and severity of injury.
Wear your seatbelt, guys. Let's see what else we got here. Got another one. Okay.
In head-on collisions, two types of injury patterns are likely. The patient follows a pathway up and over the steering. Types of injury patterns are likely. The patient follows a pathway up and over the steering wheel, commonly striking their head on the windshield, causing head and neck injuries, especially when not wearing a seatbelt. Additionally, the patient may strike their chest and abdomen on the steering wheel, causing chest injuries, breathing problems, and internal organ injuries. In the second pattern, the patient's body follows a pathway down and under, typically striking their knees on the dash, causing knee, leg, and hip injuries. In rear-end collisions, the law of inertia explains why neck injuries are common. The head remains still as the body is violently pushed forward by the seat, extending the neck backward. In side-impact collisions, the head tends to remain still as the body is pushed laterally, causing injuries to the neck. The head, chest, abdomen, pelvis, and thighs may be struck directly, causing skeletal and internal injuries. Rollover collisions are very serious because of the potential for multiple impacts. Anyone who is not wearing a seatbelt can be ejected. Any type of serious injury pattern can be expected. Rotational impact collisions involve cars that are struck, then spin, causing multiple injury patterns.
All right, let's see what else we got. All right. Let's see. So we're done with the lecture. Now we're gonna go ahead and take one more test, and we are done for today. This was a very, very short lecture. Stop sharing. All right, guys. We'll take a 5-minute break. Go ahead and log on Kahoot. A patient with severe abdominal pain had been struck in the abdomen by a baseball bat. The patient wants to keep his knees bent. What's the best answer? How would you place this patient? Oh, there you go. Lay him on his side with knees bent up if preferred. Yeah, that's because if the knees are bent up, the muscles won't contract as much and it'll cause less irritation. That's why. And less damage. All right, which of the following blood vessels are unable to vasoconstrict? Oh, a little bit of music on. Capillaries. The capillaries. That's they have no muscles inside. That's why it's just it's a vessel with no muscle layers. The arteries and veins, arterioles and venules, they all still have a membrane, a layer of muscle, which allows them to constrict. Capillaries don't. Our next one, see, during examination of a male patient with back and jaw pain, you discover a new onset of an irregular heart rate. What does this finding tell you? The patient is at risk of ongoing cardiac arrest and he may require CPR. See, during the examination of a male patient with back and jaw pain, okay, I see you discover a new onset of irregular heartbeat. That makes sense to me. All right. Which of the following is the most common route of entry of toxic substances into the body? Ingestion. Ingestion is the most common way. With pediatrics, it tends to be accidental because they're discovering the world, they're figuring things out. With adults, obviously, it's a different story. But that is the most common route. Which of the following is typically used to represent the term blood? This one's tricky. It is tricky, so don't just go for it. Blood in general. That means all blood in general. All right, you guys got it. Which with the various routes for medication administration, which of the following would be an enteral route? Enteral route. Enteral is from your mouth to your anus. That's what it's talking about, enteral. Buccal. That is in your mouth. That's between your gums and your cheeks. That's usually the term used for that, for the space between your mouth, your gums, and your cheek. Gums and your cheek. Buccal. Which of the following would be proper for a patient you suspect has a communicable disease? Isolate the patient and protect the rescuer immediately, then continue questioning. All right. All right, next one. A coworker asked your reason for ignoring an obvious broken leg on the victim. Best justification you could provide. Yeah, good. That would be a situation where we're stuck in the primary assessment. That would be a primary assessment issue, not life threat, obviously. A 55-year-old female complaining of chest pain. You're getting ready to listen to lung sounds. Most appropriate for male EMT to do. Oh, sorry, I thought you guys could hear me. I was on mute. But yeah, but if you were to do this with any patient, honestly, it's not a bad thing. Any patient that, if you tell them what you're going to do before you do it, it's gonna make any patient feel a lot easier about everything and better about you. Okay. Why is it important for us to use an accurate and synchronous clock in our documentation. Inaccurate times can be used against you later in court. Give me a sec, guys. I have to look that one up for sure. It says environmental. It could be that though, because that is actually a fact. But I just have to be sure. Because the last few tests, I think I might have been in a hurry when I was making them. See, this one is an environmental. Here we go, environmental. And inaccurate times can be used against you later in court. Yep, that's correct. All right, that's the right answer. All right, let's keep going. All right, air enters chest from an open wound and is unable to escape. It puts pressure on the lung, causing it to collapse. What else can it do? Impeding blood return. Good job. I talked about that plenty at this point. All right, why is it important to attempt to determine when the poisoning occurred? That's correct. That's the only one that makes sense to me. Which of the following divides the body into a front and back portion? Frontal plane. Good job. Choose the most common feeling a patient may experience during a reassessment, ongoing exam. Which of the following phases of generalized seizure is characterized by rhythmic jerking movements of the extremities? Clonic phase. Yeah, so it's tonic clonic. Clonic being what we're talking about right now. Regarding the movement of patients, which of the following is unnecessary? Yeah, that one's not really that important. All right, guys. So as far as Friday and Saturday, I'm gonna send out a list of what we're gonna be going over, maybe in about an hour or so. Also, for now, look over the packet of skills that I gave you. So the one that has a medical assessment sheet, trauma sheet, long bone immobilization. Go over all of those, and pretty much whatever you haven't done yet on those packets, study that. We're gonna be going over everything that has to do with how to bandage anything. So how to bandage a broken arm, how to sling and swat it, how to use a traction splint on a femur fracture. So we're gonna cover all those things that we haven't covered, and the majority is gonna be on trauma. Okay, so it's all gonna be on trauma for the most part. But yeah, so just go over those for now, and I will send out a list hopefully in the next hour or so of what we're gonna cover and in the sequence that we're gonna cover. So hopefully that'll help you guys prepare for when you get there, so we can just knock it out. Any questions for me? If you don't have any questions, I guess we see each other tomorrow, and we are going to cover. You guys are gonna cover chapter 31 by yourselves, environmental. Just go over that. And then we're gonna cover chapter 32, obstructive and gynecological emergencies, and we might hit up pediatric. If we don't hit up pediatric tomorrow, we'll go over it on Thursday. All right, that's it for me. Have a good night, guys.
All right, thank you. Good night.
You too.